Okay, let's dive into this. Welcome to today's Explainer, where we're going to step into the shoes of clinical detectives. For decades, we've kind of just thought of worsening eyesight, specifically myopia or nearsightedness, as a simple matter of getting thicker and thicker glasses. But today, we're going to look at how modern optometrists actually solve the mechanical puzzle of your eyesight. It's an absolutely fascinating, highly customized medical investigation.
Lines. So here is our patient docket for the day. First, we'll look at the tools of the trade. Then we'll open 4 unique case files: the young athlete, the topography puzzle, managing side effects, and finally, the neuroscience student.
All right, Section 1, Tools of the Trade, Equipping the Clinical Detective.
Before we can actually solve these cases, we really need to understand the modern tools at a clinician's disposal. We're way beyond just standard reading glasses now. Optometrists have a specialized toolkit designed not just to correct blurry vision, but to physically stop the eye from changing shape. First up is atropine. In the clinical notes, you'll see this prescribed frequently at very low concentrations, usually between 0.025% and 0.05%. To translate the medical jargon for us, these are daily medicated eye drops that chemically help put the brakes on childhood myopia. They literally slow down the physical elongation of the eyeball. Pretty amazing, right?
And then we have Ortho-K, short for orthokeratology. Think of this as a brilliant nighttime solution that acts exactly like a dental retainer, but for your eye. These are rigid, custom-fitted contact lenses that you wear while you sleep. They temporarily reshape the cornea, which means the patient wakes up, pops them out, and has perfectly clear vision all day without needing glasses or daily contacts at all.
Let's jump into case file 1, the young athlete. All right, here's the briefing. We've got an 11-year-old existing myope, and she is incredibly active. She plays multiple instruments. We're talking saxophone, piano, guitar, trumpet, and she's starting AFL football soon. Go the Bombers! Now, as you can imagine, standard glasses and a full-contact sport like footy just do not mix well. Getting tackled with frames on your face, absolute nightmare. She previously tried our nighttime retainer, Ortho-K, but really struggled to get the rigid lenses in and out. So currently, she's using our first tool, atropine drops, twice daily.
So, looking at her file, the clinician has to make a tough call. If she ends up continuing with glasses for her daily activities, does she need a near ad? And if so, what magnitude should it be? Take a second to think about the physical demands on an 11-year-old student who plays piano and is constantly reading sheet music up close all day long.
While the clinical decision here is actually pretty clear, the detective work shows she needs a plus 1.00 magnitude added to her glasses. Why is that? It's because of something called accommodation insufficiency. Translating that simply, her eyes' focusing muscles are just getting tired. They need a little extra help up close to reduce strain, especially since those atropine drops she's taking can sometimes slightly relax those focusing muscles. So, the crucial point is weighing her options for the upcoming footy season. Do we prescribe soft, daily disposable lenses, which are fantastic for sports but just don't offer any of those long-term reshaping benefits, or do we bring her back in to intensely retrain her on inserting those Ortho-K lenses? The clinician has to balance the ease of daily use against her previous struggles with rigid lenses, all while keeping her super active lifestyle front and center.
Moving on to Case File 2, the Topography Puzzle.
Meet our next patient on the docket. He's a 13-year-old boy, an existing myope. His primary goal is to ditch his glasses entirely. He's currently wearing a -3 prescription in his right eye and a -3.50 in his left. He wants Ortho-K or standard contact lenses. Sounds simple enough, right? But the clinical data tells a much deeper story. And this beautifully illustrates exactly what an optometrist looks at. This is the clinical vision dashboard. Now look down at the bottom row. Axial length. The previous measurement for both eyes was 22.74 millimeters. But now, the right eye is 23.03, and the left eye has jumped to 23.12 millimeters. What we're looking at here is the literal physical stretching of the eyeball over time. The clinician immediately asks, is this amount of axial growth normal, or is it greater than expected for a 13-year-old? This highlights a massive shift in modern optometry, guys. Treating myopia isn't just about making sure you can read the bottom line of an eye chart anymore. It's about tracking physical, anatomical eye elongation over time to prevent long-term disease. And this jump we just saw, that is a huge red flag for rapid progression. But there's another clue in his file we need to investigate. The patient reports that his distance vision is clear, but he gets noticeably blurry vision immediately after watching an episode on TV. The clinical detective has to ask, why? Is his visual system locking up after near work? It's another crucial piece of the puzzle that dictates exactly which lens design will prevent his eyes from overworking. Next up on the docket, Case File 3, Managing Treatment Side Effects.
This is a really frustrating journey for our next patient, who we'll call the atropine adjuster. Because their myopia was progressing rapidly, the clinician increased their atropine drop concentration to the stronger 0.05%. Now, it effectively fought the eye growth, which is great, but it introduced a really harsh side effect: intense light sensitivity. It got so bad that the patient just stopped using the drops entirely for the past week.
This patient wants to spend more time outdoors, away from screens, but the sunlight is literally hurting their eyes. So the clinician is faced with question 12. If they want a contact lens option, what on earth do you order for trials? You have to figure out how to pivot this patient to contact lenses to manage their myopia, while simultaneously finding a lens tech, maybe something with UV blocking or photochromic properties, that manages their severe aversion to bright light. It is a true balancing act.
All right, let's open our final file, Case File 4, the neuroscience student.
Meet our university student. She's studying neuroscience, which, as you can guess, means an incredibly heavy daily reading load. Interestingly, she successfully wore ortho-K nighttime lenses for years, but when she moved out of home to live independently, her father was concerned about her maintaining proper lens hygiene, so she was actually switched back to glasses and standard daily soft lenses. This perfectly illustrates how a simple life change, like moving out for college, directly impacts medical treatment choices.
Now, what's really interesting about this slide is the sheer amount of visual stress revealed in these metrics. Notice those ESA values jumping off the charts and an MEM of plus 1.50. In plain English, SO means her eyes are exhibiting a severe tendency to turn inwards. These metrics are clear, undeniable signs of intense eye muscle strain and focusing fatigue from all that neuroscience studying. Her visual system is basically exhausted.
And this leads to the ultimate puzzle for our clinical detective. What is the best management option for her now, and why? You have to weigh her massive academic reading load, her previous success with overnight reshaping lenses, and her current massive eye strain. Do you put her back in ortho-K to relieve daytime strain? Do you prescribe specialized anti-fatigue glasses? The answer requires synthesizing her entire life story.
Let's move to our conclusion and see how this all builds together. The core takeaway from these university case files is that modern optometry has moved far beyond the old days of simply asking number 1 or number 2. It's highly tailored, data-driven medical detective work. Every single patient's lifestyle, habits, and eye anatomy create a completely unique physiological puzzle.
Which leaves us with this final thought. We've seen how studying, screen time, and even taking up footy alters clinical eye care. As our digital lives continue to grow and demand more of our close-up focus, how might your own daily habits be silently reshaping your vision without you even knowing it? It might just be time to book your own comprehensive eye exam and find out. Thanks for joining me on this explainer, and I'll catch you next time.